Thank you everyone for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover meaningful use, attestation, audits, and appeals. We're joined today by Jim Tate of EMR Advocate. Jim is one of the top meaningful use experts in the country, and he has helped to guide both eligible professionals and hospitals through the audit process. He offers invaluable real-world insights into the audit process, along with practical advice for anyone who attests and may face an audit. And later we'll show another website that he has as well, Meaningful Use Audits, but we'll go into that a little bit later. You can look at Jim's experience a little bit while I go over a couple of quick housekeeping notes. Before we begin, remember that you can ask questions of our presenter at any time during today's session by entering them into the chat area. In the second half of our session, we'll address as many questions as time allows. If we do run out of time, answers to those questions will be posted to our website and sent via email link later in the week. Also, after today's session, you'll receive an email with links to both the slides and the recorded version of this event, and that'll go to all registered attendees of today's session. So if you're looking for those slides, we often get questions about that. We will send them out after today's session. Well, Jim, first of all, thank you for joining us. It's always a pleasure to be able to share your expertise with people.
Well, I appreciate it, Brian. Good to be here with you again. And there's so much that's been going on with kind of anecdotally and kind of one-off experiences with providers going through attestation, then audits, and then potentially appeals that I look forward to kind of discussing some of the things I've run across in the last few months.
Yeah, and there's just huge hunger for information about this subject, so why don't we begin? And this is a great question to begin with. What are some common mistakes that providers make during the attestation process?
Yeah, you know, this is a great one because it kind of goes back to 2011, which the stage was set for some pitfalls and problems. Because that was the first year of the Meaningful Use Incentive. There was not a lot of clarification, not a lot of guidance, just a lot of knowledge gaps around a lot of these issues. And so one of the big ones was, you know, as we're all aware, there are two EHR incentive programs, Medicare and Medicaid, and if a provider can ever qualify for the Medicaid program, that's without a doubt always the best one to go for. And so, but you have to meet certain volume requirements to be considered Medicaid eligible professional. And so that's one of a common mistake is that there may be that Medicaid EHR incentive is claimed and without really meeting those volume requirements. So that's not uncommon. That happens pretty frequently. Another one is attesting to the meaningful use measures without verifiable documentation. Brian, this can happen a lot of ways. Somebody called me yesterday from a practice that's actually going to an audit now, and they attested, but they can't locate any of their documentation. And what little they can locate does not validate against running new reports out of their current system, so it's not really verifiable documentation. And one of the job was, of course, during attestation is it's so easy when the question is asked, have you performed a security risk analysis? The yes or no question. And it's very easy to say yes. But if you don't understand what the requirement is as far as that security risk analysis, you could say yes to it, even though you really haven't done it, just because of a knowledge gap. And during an audit, that's one of the first things you want to see is that security risk analysis. So ignorance of the rules or just lack of knowledge about the rules is really not going to be a valid excuse. So that's something we saw a lot of in 2011, 2012, and even 2013, still seeing a lot of these common mistakes being made during attestation. I think the one thing is that sometimes the person actually doing the attestation, one of those web-based forms and inputting information don't have clear understanding of what they're attesting to. And so to me that may be the biggest mistake is having somebody doing the attestation who doesn't really understand every aspect of it.
Sure, and these are themes that have I've heard from you in the past around the importance of documentation, and then how many people seem to get tripped up on claiming that they've had that required security risk analysis, and then when upon examination it really never was there, or it's not adequate. So I'm sure we'll hear more about that.
Right. Yep. Or out of date.
Right. Right.
Sure. Exactly.
So those are some of the struggles that people have. What are some best practices that you could recommend for attestation?
Yeah, these are some of these are in the maybe the bucket of lessons learned. Definitely accurate registration information. Of course, a provider can register at any time, and then when they achieve meaningful use for a certain reportable period, they can actually do that attestation. But during the registration, the initial registration, contact information has to go in the system. It's at the CMS website. There's a registration web forms that are filled out. And part of the information they will know for whether it's a hospital or an individual practitioner is the contact information, and that includes the email address. And so if at some point down the road there is a decision made to audit your attestation, there's going to be an email going out to that email address. And so if that contact information that was put in during attestation was from somebody who's no longer with the practice, or that email address inbox is never checked, nobody's going to know that there was an audit that came through. And so the auditors will definitely follow up if they don't want to hear back, but definitely want to make sure there's accurate registration information in case the auditors or the appeal bodies want to get in touch with somebody because you're putting your contact information. Appropriate meaningful use strategy. This is critically important because during attestation, decisions are being made as to whether a provider or a hospital can exclude some core meaningful use measures, or also making decisions about which of the core measures they want to exempt themselves from or defer. And a wrong decision on that strategy can kind of get in trouble during an audit because maybe you end up failing some measure that you didn't even have to attest to. You could have attested to something else, another measure you could have met very easily, especially in the menu measure. So there really has to be a meaningful use strategy as to what you're going to attest to. During attestation, always, everybody should touch base with their vendor. The vendors have had hundreds, and some have had thousands and thousands of providers achieve meaningful use, register, attest, and receive those incentives. And so some of the documentation that's going to be required for attestation or as saved information, one of the first things that's asked during attestation is, what certified electronic health record system are you using? And you go to the CMS website and get the number of your EHR or collection of modules, and you input it in that system. Well, during an audit, one of the first things that they are going to want to see is actual proof from that EHR vendor you claimed was yours in terms of a letter of purchase or some type of contract or some type of agreement. They want to see that. So some of the documentation that you claimed during attestation, you know that the vendor is going to be the one who actually hopefully provides it to you. I mentioned here also save all documentation. I touched a minute ago on somebody who called me yesterday, attested in 2011, and now they're being audited, and they cannot find their documentation. In particular, documentation they can't find is really the easiest documentation, which is the meaningful use numerators and denominators that come out of their certified EHR, those meaningful use measure numbers. And when they go back and try and recreate that report, they get different numbers now. The reason why is because since 2011, their EHR vendor has upgraded software numerous times. It affects the report output, and so they cannot recreate what they attested to. They just never saved that paper documentation. And the last one here, make sure you attest, is kind of you think, well, how could that happen? But I had a call several weeks ago from a hospital that attested in 2011, got a significant amount of incentives. And then in 2012, they did a full reportable year of meaningful use, met all requirements, but for whatever reason, they did not attest. And whether it was a staff change or something, who knows what happened, but they did not attest and then missed the deadline. And so they lost an entire year of meaningful use incentives. And you can't go back and get that now.
I was going to say, there's no recourse then to the provider if they do miss that deadline?
No, and this is a hospital.
Oh.
You can imagine significant numbers. And so there's a deadline when you're able to attest within, and you cannot attest after that deadline. So even though it seems like a kind of a minor thing, make sure you attest. I've seen cases where people didn't attest, and then they can't go back. So.
Well, that's all great advice. So you've talked already a couple of times about documentation and how important it is. And what exactly should practices keep then?
There's absolutely no doubt anything that's printed out of your system and out of your certified EHR, there's going to be some typically meaningful use dashboard and a clinical quality measures dashboard. All those numbers are going to be reported manually during attestation. But not only do you get those numbers and input them in a CMS website, web-based forms, but you want to make sure you have hard copies of those and you save those. And there's just no doubt that paper documentation that you've relied on for attestation, you've got to save it because it can just cause a lot of trouble. I'm working with a lot of people now who cannot put their hands on it, which is a really big problem. So those are the main things. There's a lot of confusion around some of the issues about some of the yes/no meaningful use measures that are non-percentage based. Example would be, was clinical decision support enabled during the entire reporting period? A lot of confusion about how to really document that because there are hundreds and hundreds of EHRs out there. There are some ways where you, during the reportable period, for some EHRs, you're able to do screenshots that show that the clinical decision support has fired, or maybe there's an EHR may have the ability to actually generate in its audit log when that is turned on or off, or sometimes for some EHRs it cannot be turned off. It's hardwired on, and a letter from the EHR vendor saying this cannot be disabled, it's always enabled, would typically be adequate documentation. So some of that documentation, depending on your EHR, could come from various sources. Again, it could be screenshots or just a letter from the vendor with their logo on it and signed by somebody in their organization.
That's great advice for some of these ephemeral things. You know, we've heard the same advice from HIPAA experts that, you know, there's nothing wrong with taking a screenshot and dating it, and then you've got a form of documentation that, you know, is better certainly than having nothing.
And in some ways, I feel some sympathy for auditors when they're having an audit, because they're auditing vendors with literally hundreds of different systems, and these systems vary widely in how they can provide this documentation. So.
And we had a question from the audience. We usually save these, but in talking about the meaningful use reports, a lot of these are then the numerator-denominator based figures that need to be attested to. Is that what you're talking about?
Yep, that's exactly right. Those are the percentage-based ones.
Yeah.
And the certification requirement is that the systems have to generate those meaningful use percentage-based numbers. All the yes/no ones about if a certain functionality was enabled the entire time, or did you do security risk analysis, those kind of issues don't have to be in that printed out report. It's really other documentation that is provided. In case security risk analysis, they'll want to actually see it. You upload it to them typically so they can see it. Make sure you have one that's dated.
So let's say that someone does face the unfortunate consequence of being audited. What are the steps they can expect?
Sure. Well, the first thing we touched on a little earlier is there's going to be an email letter. If somebody is in the Medicare program, or in the case of hospitals that are dually eligible, Medicare and Medicaid, the letter of engagement, as it's called, comes from a CMS website, a CMS email address, and it actually comes from an auditor at Gigliosi Company, which is the group that was awarded the contract to do audits. So they do all the audits for Medicare and Medicare/Medicaid dually eligible hospitals as well as professionals. If someone is in purely only the Medicaid program, that letter of audit is done on a state-by-state basis. So each state's Department of what the equivalent of HHS is who that letter will come from. But for most people on this call, to get one, it's going to be a letter by email, and it's going to be a request for documentation. And initially, that letter asked for all documentation that was used during attestation. And the audit that's taking place is for an individual attestation year. So the audit could be for your attestation of 2011 or your attestation of 2012. In the case of a hospital, that audit is against the entire hospital's incentive. If a practice has 4 or 5 physicians, of course the meaningful use incentives are on a provider-by-provider basis. So one member of a 4 or 5 provider practice, professional practice, may be audited, and others may not. I've seen where everyone's been audited, where only one's been audited. So that letter is really coming either to a hospital or to an individual healthcare professional, and it's looking at an attestation for a particular year. That request for documentation is going to include everything that was used during attestation. And again, that's the meaningful use reports. They will put documentation, the clinical quality measure reports, security risk assessment, proof that they actually own the EHR or had legal access to that EHR that was claimed during attestation. Anything that's claimed during attestation, they want documentation about. And typically there's 10 business days to respond with that documentation. There are a couple of ways that information can be exchanged securely. There's a secure portal where things can be scanned and uploaded, or if they're electronic files, uploaded to that portal. Different ways to get the information to your auditors. And I have found that many auditors, if you need a little more time, if I got an audit next Monday, Thanksgiving week, and saw the people out of town that week, and it's got a 10-day delay on it, I get in touch with the auditor, say, you know, it's going to take an extra week, and I've never seen a case where they would not grant an extra week. You can ask for 6 months, they won't give you that, but there's some flexibility in the time there, in my experience. You give them that documentation, they review it, and if they have any need for more clarification, grounds for documentation, they will ask you for it specifically. So you have a sense of if you've met all the measures and everything is good, or if they need some more information, they'll ask you for more information. At some point, there's a letter of final determination that comes in, and I've seen audits taken care of in less than a month. When somebody had their documentation and was ready to do it, when they received an audit letter, I've seen some drag on, especially in the early days. By early days, I mean a year ago when the audit process was new, where these could drag on for 4 months. So as everybody was figuring out what type of documentation was needed. But at some point, there's a letter, and that letter is a letter of final determination. And it either says you've met meaningful use and you're good, or it says you have not met meaningful use, and it specifically says what measures you failed.
And Jim, is that letter from the auditing body itself? That's a third party,
Yep.
Isn't it?
Mm-hmm.
Okay.
It comes directly from the auditing body.
Okay. So what are some other things people should know about the auditing process?
Well, there are some built-in. Actually, when during attestation, when you're someone is doing the web-based input of those numerators and denominators, there's actually a process of auditing that's built into that. The reason I say that is because there are a number of numerators, a number of denominators for the meaningful use measures, which are based on number of unique patients seen by a provider or number of hospital discharges in the case of a hospital. And so spread across a number of those measures is a denominator that should be exactly the same for every measure. And so if that denominator should vary from one meaningful use measure to another, there's obviously something wrong there. And so there's almost a built-in process to detect those inaccuracies. Now, pre and post payment audits have begun. The post-payment audits started in the summer of 2012. Somebody would attest and usually receive their EHR incentive within 4 to 6 weeks. And then maybe sometime after that, there may be a post-payment audit. But beginning this year, early in 2013, prepayment audits started taking place. And this would be somebody would attest, submit their attestation, and before they received incentive they get an audit letter saying your incentive is held up until we make sure that you have successfully met meaningful use, and they'll do an audit. Now, the kind of hard news about this, and I talked with somebody yesterday, it was kind of a sticker shock item, is that if you're ineligible, you must pay back the incentives. Now, since the audit is taking place against a single year's attestation, that is the incentive, if you've already received it, that really is at risk. And it's 100%. If you fail one measure, then the entire incentive is due to go back or not be received. So it's not a percentage-based thing. It's all or nothing. You either achieve meaningful use or you don't. And if you don't achieve meaningful use, you're not going to get that incentive, or you may have to, you will have to give it back. Unless you leave the country, maybe. That's the only way to not have to give it back.
Right, and that would also carry certain complications.
I bet it would, yeah.
So apart from the measures you've already talked about, what can providers do to get prepared for an audit in case it happens?
Yeah, sure. I've seen quite a few very, very smooth audits, and these were by hospitals or individuals who really were prepared for an audit. And by that I mean they had, during attestation, they gathered all their data, security risk assessment, everything that necessarily printed out of their system. Asked their EHR vendor for help, providing some other documentation they may need, and punched holes in it, put it in a 3-ring binder, and put it on the shelf. And then if they're audited, and I mean, this is exactly what I've seen a number of times, that documentation goes up, and within 2 or 3 weeks, sometimes I've seen they get that letter back and says everything's fine. So, so it can really not only kind of almost ensure that you are okay during audit and achieve meaningful use, but also that you're prepared for that audit if you have one. So I'd keep all that documentation really in one place, and somebody needs to know what it is, because people change jobs, people move, and that audit may not take place for a few years down the road. So that documentation really needs to be available.
All right, well, we've already got a number of questions from our audience. I want to remind everybody that we're going to save those questions for the end, and then we'll share them with our expert and try to get you the answers you're looking for. But you can go ahead and ask now if you'd like, or save those questions for later. So how big of an issue are these audits, Jim? Are a lot of providers going to get these?
You know, and these, well, you know it. A year ago, almost, we hardly heard of any audits. I've asked vendors, I've worked with many vendors, and I've asked vendors, has anyone been audited? Every time I do a presentation or talk to people, I say, do you know of, anybody who's been audited? And I would rarely ever hear yes. And then about 4 or 5 months ago, I started hearing more and more yeses. And then, especially the last 3 months, very common. Everybody knows somebody's been audited. Surprisingly, and when I looked up these numbers at the CMS website, as of a couple of months ago, over 4,000 unique hospitals and over 300,000 unique eligible professionals have received CMS incentives. That's to me, that's a successful rollout. But that many people have actually achieved stage 1 meaningful use. Those are great numbers. And CMS states that the aim is to audit somewhere between 5 and 10% of those attestations. So a lot of practices, a lot of individuals, a lot of hospitals are going to see these. There's no doubt about audits, and this is going to continue throughout the entire EHR incentive program. That we're just partially through it. These audits are going to go on for years, so we're just really starting to get into the deep end of the swimming pool with them. There'll be a lot more audits when we're finished.
And so does it look to you like they're on target for that 5% or even more than that?
That's something that I've asked auditors, and I've asked individuals at the appeal level, and I have never been able to get an answer about the data about how many have been audited, how many have passed, how many have failed, how much money has been recouped. I've yet to find out any of that information. I would love to know it, though.
But it's certainly significant numbers.
Yeah. Mm-hmm.
So why might a provider then be selected for an audit?
Yeah, that's the question.
It's the million-dollar question.
Right, I know. Why me? There's no doubt that some are selected at random. Probably just like the tax audit. There's got to be some randomness to it, and that's both for the prepayment and post-payment. Others are no doubt because that's suspicious data. We mentioned when we were talking a couple slides back, Ryan, about where maybe on a number of meaningful use measures, the denominator should be identical because it's unique patients, unique discharges, something like that. And it would not be very difficult at all to run a database query against many meaningful use attestations and immediately kick out a list of ones in which obviously there's erroneous data there. I have seen in 2011, a lot of the EHRs were not sure how to really program their systems to generate these meaningful use measures. And so I saw some situations in which meaningful use measures like for problem lists would be, I saw one recently that came out and said they met 112% of the goal. Well, it's impossible for the numerator to be larger than the denominator in meaningful use. And so sometimes this suspicious or erroneous data is a problem with algorithms in the EHR, or it is because an attestation has been made, and I've seen some of these where whoever did the attestation put the exact same numerator, exact same denominator on every meaningful use measure when they attested. Obviously, they didn't know what they were doing, and they were just putting in numbers. So anything like that is definitely going to raise a red flag. And I also mentioned here whistleblowers. I don't know how large a thing this is, but I have had a number of vendors and other stakeholders in health information technology who are convinced that they are aware of either people who are claiming to be using their EHRs but for meaningful use, but they're not. I don't know if it's any longer available, but CMS used to put out a giant spreadsheet that it showed providers and what EHR they had attested to during their meaningful use attestation. And vendors would look at that and pick out people and say, those are not my users. Whether it was intentional, not intentional, who knows why they came up with those wrong numbers. But some of those vendors made phone calls. CMS does have a way to report if you think that there is some type of willful or unwillful fraud going on with the system. So I'm sure that that's being tracked also.
Now, Jim, is it the case that if it is a case of willful fraud, if you will, rather than just, not meeting what you're supposed to do, are they subject then potentially to even higher penalties beyond giving back the incentives?
I haven't heard anybody being sent to the pokey yet, Brian, but I remember a year ago at the HIMSS conference, or a year and a half ago, CMS said that the Justice Department had no interest whatsoever in receiving information, that this was considered an incentive program and really was not, did not fall under the False Claim Fraudulent Act situation. However, 4 or 5 months ago, I read interviews with some of the CMS management, and they say that they had uncovered suspicious things and had turned that over for investigation to the Justice Department. So I've never heard of anything from a criminal nature happening yet. And again, 2011, and I think most mistakes are well-intentioned.
Sure.
Not intention to fraud, but I'm sure there is some legitimate concern for fraud there, and I think they're going to take that very seriously. And I think sometime we're going to hear about somebody, who has some hospital someplace who played loose and fast, and they're going to get in some real trouble.
So let's say that someone does get that audit letter. What's the basic shape of that letter look like?
Yeah, this is the first paragraph, I guess, from one of the Medicare/Medicaid letters from Figliosing Group. I sent it to my email. This is informing you've been selected, and this is the information request, and we want all the documentation you have, and we may want additional information. So this is the actual wording that it really is the first contact that you get. To tell, of course, there's more information than this, but this is what the audit letter looks like, and this is the phrases around it. The only other thing that be a little more specific is it will identify the exact attestation year. It may say year 1, 2011 attestation, or year 1, 2012 attestation. They'll let you know exactly what year you're being audited for. So it's a very simple document, really.
And then what does the demand letter look like then?
Yeah. Well, let me say, I want to say just a second about that audit letter. When that comes in, that should, and since there's going to be a deadline of a few weeks to respond to it initially, it should be escalated very quickly to highest levels. In 2011, a lot of hospitals received $1 million, $2 million, $3 million, $4 million, and more dollars for the EHR incentive. Some of these were very small critical access hospitals, and some hospitals, people wear a lot of hats. But we want to make sure that if that audit letter comes in, it doesn't just go in the bottom of somebody's drawer someplace. It needs to start being taken care of very, very early, and really treat as a priority, because it is a priority. Okay, yeah, you want to go about that demand letter?
Yeah.
Yeah, this one is the one that you don't want to get. During the audit process, documentation is exchanged back and forth. It could take weeks, it may take a few months, but at some point, those auditors are going to make a final determination. And in that final determination, they're going to tell you you either passed or you failed. And if you failed the audit, they're going to tell you specifically what meaningful use measures you failed. And they'll also say you're going to get a recoupment letter soon with your appeal rights. This is an example of actual wording edited out a little bit of a demand letter. And this is where it's saying this is to inform you that you've got to repay that incentive for that was paid out to you, if it was paid out to you in full. And they want a full refund within 30 days. On the 31st day, interest begins. And the interest that I have seen usually varies from 10 to 10.5% annual. So it's, figured, I'm sure, on a daily basis. Interest begins on the 31st day. And they say that you'll be referred if you don't pay the Department of Treasury on the 61st day. And I don't even really want to know what happens once you get to the Department of Treasury, but it is a sequence where at that level they start with letters and phone calls and escalation there. But one thing that's kind of fascinating is the last statement up there, that if you fail an audit and you appeal, just because you're appealing does not put your interest penalties on hold. And even if you win the appeal, the interest is still due. If you receive a letter that tells you final determination you failed, and then you get a recoupment letter that says we want the money in 30 days, and you appeal that day, the queue is so long for appeals that it is extremely unlikely that your appeal is going to be heard, and you're going to get notification of it within 30 days. So if you're at this point, there are going to be penalties unless you pay that money back within 30 days. So the safest thing to do is when you get a demand letter and you're going to appeal, you go ahead and pay the money back. And then you appeal, and 1, 2, 3, 4, however much it takes to go through the appeal process, at least you won't have any penalties. If you win under appeal, then you get your money back, the incentive back. If you lose under appeal, then you actually already paid your money back, and you don't have to pay any more back. So I've worked with some hospitals, and they were in the position of, well, it says that we have to give back $700 or $800 or $1 million, but we think we can probably win the appeal. So we don't want to have to come up with all that cash right now. Well, they might win the appeal, but at that 31st day, they're going to start generating interest payments, interest amounts that they're going to have to pay even if they win the appeal. So the big goal is to successfully meet the auditor's request and pass the audit, because once you go to the appeal level, some of your destiny is outside your hands. It gets much more complicated because then you're talking about money and deciding, well, should we give all the money back and hope we win the appeal and not have penalties? And there's kind of decisions that you hopefully don't want to be in a place of having to make. So.
Let's talk a little bit about some of the best practices you found for people getting through audits.
Sure. And this is the same song we've been singing on a number of these issues. Having someone in charge, whether it is a hospital or a fellow practitioner, somebody's got to be in charge of this audit. They have to be the ones who are responsible to meet those deadlines, to call up the EHR vendor and say, how do I get this documentation? Somebody's got to own this process, very, very important. Don't make too big an aside, but, as we've learned more and more about the Affordable Care Act's website and the problems with that website, I don't think there's anybody who was ultimately in charge. There's maybe a lot of people who say, well, there may be a problem here, but that's really not my responsibility. There was no one who was really in charge, and just a bad process. So having someone in charge, establish contact with the auditor. As soon as I get that email address, I would email the auditor back and say, I'm gathering information here, something like that. I'd also contact my vendor and say, I'm going to an audit here. Every vendor has had users just about who've gone through audits. They have a lot of experience with helping provide documentation. You'll make sure you don't miss those deadlines. If you don't think you can make a deadline, contact that auditor, let them know, and ask for some little grace period there. Typically, I've seen that received, and seek counsel if needed. And just counsel, I'm not talking about necessarily calling a lawyer. I'm talking about if many eligible professionals were helped by regional extension centers to select EHRs and achieve meaningful use. They know a lot about the documentation required here for these audits. So if you've used a regional extension center before, I'd go back to them if I received an audit. Or even if I haven't, I'd contact one, see if they could help me. So you want to make sure that you really get all your resources together.
So if people do reach the point where they're going to try to appeal an audit, how does that work?
Sure. And let me say, there's never a reason not to appeal. It may be if you fail an audit because you don't have a security risk analysis and you appeal that, you're still going to fail the appeal level because they want to make sure that you have that. However, there are some real reasons to appeal. It's some documentation that you provide at the appeal level. It's not to the contracted auditors. It's really at the CMS level. The appeal takes place, and there are some ranges of some options at the appeal level. Perhaps there was some misunderstanding that you now understand, and you could document something that you didn't know you could document during the audit, or you for your first year when you only had to do 90 days, if you could meet meaningful use for a different 90-day period. That's one of the questions that's asked at the appeal level. So CMS is going to handle those for the Medicare and the dually eligible hospitals, and the Medicaid appeals are handled at the state level. But, there's no downside to appealing, no downside. But sometimes it is a useless exercise because if you just did not do some things, again, security risk analysis is a great example, and you fail an audit because of that, well, nothing's going to work out at the appeal level either.
Yeah, you can't go back in time and do it retroactively.
Yep. Right, yeah, and these are some of the things here about that I kind of mentioned, Ron, that you got nothing to lose. The appeal process doesn't cost anything, but and there is some more flexibility, and by flexibility I mean options of different reporting periods, or maybe you learn something during the audit period, the audit process that you can kind of bring to bear to maybe provide additional documentation or a different explanation or clarification. In my experience, there has been less communication at the appeal level than with the auditors. With the auditors, they're asking you for information, you're providing it, it's going back and forth, back and forth. From what I've seen so far at the appeal level, you fill out the appeal form. This is true for hospitals as well as eligible professionals. Fill out the appeal form, and you are really just going to be addressing issues related to meaningful use measures that you were failed on. And you come up with your best strategy or defense or argument and additional documentation, whatever you want to call it, and you put that in the package and you email it in, and at some point down the road you hear back yes or no. So not quite as much back and forth at the audit level. That timeline of the appeal process, I only have anecdotal information, but I've had a number of appeals from individual eye doctors, chiropractors, individual professionals, and the appeal process took over 2 months. And again, it was not a back and forth process. We filled out the documentation, sent it in. We would call into the EHR incentive information site, ask them what was going on, and they say, well, it's still pending. After 2 months, we get information back. So from what I see, it takes at least 2 months to go through that process. And again, the only things that are really dealt with at the appeal level, it's not a complete new audit, only going to deal with those failed meaningful use measures. Those are the only things that need to be addressed. And once again, something that could be very significant for a lot of people, a different reportal period is an option. So if there was some confusion and you thought you met meaningful use during a certain 90-day period, your first year meaningful use under Medicare, but you didn't, well, possibly there's another 90-day period when you could have met it, and that could be something to bring up during that appeal documentation.
So then what are best practices around appeals?
Well, no doubt, do something different. Obviously, whatever the game plan was, the process that was used during the audit, whether it was the personnel involved, the strategy involved, documentation involved, something was wrong because you failed the audit. So something different has to be done. And again, frequently, even if this is early Medicare 2011, 2012, stage 1, that's $18,000 going back. And to suddenly be told, write a check within 30 days for $18,000, that's a lot of money. Hospital, millions of dollars. And so there's so much at stake that I would definitely do something different. I would revise some new strategy or clarification or guidance. There was either the audit process was not properly handled, people didn't really have an understanding of what they're involved with to go through the audit process, or they thought they were meeting the expectations of the auditor and found out too late they were not meeting those expectations. So something different has to be done at the appeal level to get that negative audit reversed. Now, I always say, I tell a story to keep it simple. These appeals, when somebody goes to the appeal level, the appeal staff is going to ask the auditors to upload to the portal they have access to, all the documentation and all the email exchanges that's gone on through the audit process. So they're going to have access to all that. To me, it'd be very confusing. Lots of documentation, lots of confusion, people asking for clarification, guidance, almost like spaghetti. And so what I would really recommend at the appeal level is you really identify those measures you failed and as clearly as possible discuss why you think you should not have failed those. Keep it as simple as possible. Provide different explanation, different guidance, different clarification, and always leave the door open. And by that, I mean that if there's one or two measures that you failed an audit on at the appeal level, with this new view, new strategy, new documentation, new guidance, new records from your EHR, or something like that, I would always say that what I'm presenting is new documentation or explanation to make sure that they really look at it again. I think these both auditors and appeal staff are overwhelmed with volumes of these things. So we want to make it very simple for them, tell that story, and if there is some additional documentation that would help them make their decision in your favor, I'd love to know that. I'd say, if there's some other things that you would need, please let me know what that might be. So we have to do something different at the appeal level.
All right, well, we've saved some time for questions, and we already have a number of questions from our audience. So I'm going to go ahead and start sharing those with our expert. If you haven't asked your question already, please do so. And if we don't get to your question today, Jim will follow up with a written response that we'll share with everyone. So the first question is, does one need to register for year 2013 if we already registered back in 2012?
That's a great question. No, you only have to register once. You register once, but your attestation takes place every year. One thing that's kind of interesting is, let's say somebody was going to attest their first year of attestation in 2013. They could have actually registered back in 2011. That's fine. Or if they didn't want to register back then, just get it out of the way, they could actually register for 2013 the day before they attest, and then go back the next day and attest. A lot of flexibility there, but you only have to register once.
All right, so you have to attest each year, but registration is a one-time deal.
That's correct.
So here's another question for you. and it touches on the security risk analysis. If there are measures that are not as detailed as the auditors would like, for example, that security risk analysis, is there anything we can do to satisfy them, such as showing an internal audit that identified weaknesses in our process and the steps we took to rectify these?
Well, I'm not quite sure. That sounds pretty close to security risk analysis.
Yeah.
Yeah. Now, definitely what I think they're looking for, and again, I'm not a security expert, but they're looking, and really the security risk analysis is a subset of HIPAA. This is it's the protection of electronic health information. So to identify risk, some of it's hardware. Are their servers secure? Are there uninterruptible power supplies? Are there backups? You know, wherever they may happen. Things like that. Software, is antivirus software being used? Things like that. What are the policies around passwords? Having new passwords every so often. If a Wi-Fi system is being used, is the Wi-Fi encrypted? So it's really looking at hardware, software, and workflows to identify any risks. And I've never seen a perfect one. Of course, there's going to be some risks there, but that's the purpose of it, is to identify those risks and then come up with a plan to mitigate those risks. You don't have to fix everything all at once, but and to me, the security risk analysis, Brian, is a living document. It's never finished. As if you open a new practice, or you bring in some new computers, or as things change, that analysis is going to be updated. So you're not really creating a new one every year. You create one, and then it's reviewed and updated every year.
That's certainly what our HIPAA experts have recommended, is that even in cases where nothing's changed, a practice should get that risk analysis out once a year, look it over and attest again, just make a note in that document that, you know, we've reviewed it for this year and there's no significant changes to the security environment.
Well, that's right. And so if you did your initial one in 2011 and 2012 attested for Meaningful Use again, that document by the end of that reportable period needed to have come back out. Somebody needed to review it and signed and dated it.
Yeah.
So, and it's really a great idea, because we're identifying risks, because everybody's stealing information all the time, and the only reason that health information is not being stolen is because there's not much value to it. The only true value to it is identity fraud. If they can crack in there and get demographics and social security numbers, they can do identity fraud. So the breach of that information, from that standpoint, is very valuable. So, you know, the banks and a lot of these other organizations have really protected that kind of information. It's kind of new, maybe not at the hospital level, but at the provider level, practice level, to really bring that level of security up. You know, before we just had paper charts, we'd lock the door and go home. You know, that's not good enough anymore.
Yeah, and one of the things I think is a little funny about that is, you know, HIPAA requires that risk analysis even if you don't take meaningful use money, and they sort of just sync the two up with meaningful use, saying, well, look, you should be doing this anyway, but you really need to have this risk analysis if you're going to attest.
Sure, sure.
So I'm leaving this screen up just so people can see some of the resources we have here, but we do have time for maybe one or two more questions. This question is, if one of your physicians are audited and fail, will that trigger the rest of the physicians in the practice to be audited as well?
I don't know if that's true or not, but and kind of a question that goes along with that is, if I'm audited and failed, are they going to audit me for the year before or for next year? And so
that's the next question, actually. If a clinic has been audited, are they going to get audited again?
Yeah, and so no, the people who know, well, aren't talking and aren't telling us. But I would say that it certainly does not lower the chance of you being audited again. And again, this is just anecdotal, but if I was doing an audit process and I audited somebody for 2013 and they didn't have a security risk analysis, I'd look and see if they got an incentive in 2012, and I'd audit them for 2012. If they don't have it for 2013, I know they didn't have it. So
Good point.
I would. It certainly increases your exposure. Whether they're actually generating lists based on that, I don't know, but certainly, it's a risk of exposure. There's no doubt about that.
Can an audit be performed for years past that, so we're in 2013, could they do one for 2011 now?
Yeah, I'm seeing a lot of 2011 ones. I sure am.
That's interesting.
Yeah. And those are particularly difficult because there was a lot of clarification and a lot of guidance in 2011. There was a big rush to attest and get those incentives. And the CMS clarification guys was not clear. The vendors were not clear on a lot of this meaningful use documentation. So I'm involved with a number of 2011 meaningful use audits and appeals right now, and I get calls about them every day. So those are still active. I've also seen 2012 ones, and I've seen prepayment, pre-incentive 2013 ones, quite a few of those.
So any of those years are fair game.
Yeah.
Well, I'm afraid we've run out of time, but again, we didn't get to all the questions, but we'll send out written responses to those. So thank you for your questions. We had some really great ones from the audience today.
Yeah, they were appropriate. Yeah, great ones. And
I want to thank you, Jim, for joining us.
Thank you. Again, I've actually, so much interest in meaningful use, I've set up a website just for it, meaningfuluseusaudits.com. I do a lot of blogging and information there, so glad to help out any way I can.
And you can see those URLs there on your screen, both at the top and down on the bottom under the EMR Advocate logo. So if you'd like more information, please visit Jim's sites, and he'd be happy to dialogue with you about any of the needs that you may have.
Right. Thank you so much.
Well, thanks again, Jim, and thank you to all of our attendees. Remember that all registered attendees will receive an email with links to both the slides and the PDF, or excuse me, the recorded versions of this session, and look for those answers to your questions as well. Do you need training in meaningful use? Well, check out Format Approved's Meaningful Use course. It provides comprehensive training for both eligible professionals and eligible hospitals on Stage 1 and Stage 2 of meaningful use, with lessons on clinical quality measures, HIPAA considerations, and more. You can see the URL there on your screen. That's formatapproved.com/education/courses, cmup.html. And we talked a lot today about the security risk analysis. Format Approved provides that meaningful use risk analysis that you need to attest. If you'd like more information, visit the second URL there on your screen, the Format Approved URL. That's formatapproved.com/education/HIPAA_secure.html to learn more about Format Approved's HIPAA services. You can learn more about our other training offerings by going to www.formedtraining.com. You can learn about our upcoming learning lunches by going to formatapproved.com. There's a button on the bottom of the screen that will take you to the entire slate of upcoming webinars. Our next learning lunch will air tomorrow, November 20th, and has the title, The HIPAA One-Day Training Challenge. Keep an eye on your email box and our homepage for other upcoming topics, and thank you again for joining us today.